Nesidioblastosis, rare, potentially life-threatening, but treatable when recognized.
Hi, I'm Dr. Mustafa El-Safti. Today we'll break down Nesidioblastosis, from neonates to adults, including post-bariatric cases, with a clear diagnostic algorithm, pathology essentials, and evidence-based treatment options you can use in practice. I'll reference current international guidance and practical tests you should never miss. By the end of this video, you'll be able to 1. Define Nesidioblastosis and its clinical presentations. 2. Know the key diagnostic tests and when to use SAXT ASVS. 3. Choose first-line medical treatments and understand surgical indications. 4. Counsel families and adult patients on outcomes. Nesidioblastosis is pathologic beta cell hyperplasia, or neoformation causing inappropriate insulin secretion and hyperinsulinemic hypoglycemia. In infants, it's the major cause of congenital hyperinsulinism, or CHI. In adults, it presents as NIPHS, sometimes triggered months to years after Roux-en-Y gastric bypass.
Too numerous, too large, or improperly arranged beta cells drive unregulated insulin secretion. Result, insulin release untethered from need with dangerous hypoglycemia.
Presentation varies by age, creating two distinct but related clinical challenges. A noteworthy subset occurs after bariatric surgery, most commonly Roux-en-Y gastric bypass. Altered anatomy and hormonal responses, including GLP-1, can trigger exaggerated, inappropriate insulin release. Neonates present with severe, persistent fasting hypoglycemia and seizures, often resistant to standard feeds.
High IV dextrose may be required to maintain safe glucose.
Adults more commonly have postprandial neuroglycopenia, though fasting episodes can occur.
Symptoms typically 1 to 4 hours after a carbohydrate-rich meal.
After bariatric surgery, symptoms usually begin months to years later and are often postprandial.
Shakiness, sweating, confusion, irritability, palpitations, blurred vision, anxiety, profoundly disruptive to daily life, affecting ability to work, drive, and function safely.
Capture a critical sample during a symptomatic hypoglycemic episode. This is the single most important clinical action.
Document plasma glucose, WMR 3.0 mol/ml, on 55 del at symptom onset.
Draw plasma glucose, insulin, C-peptide, proinsulin, beta-hydroxybutyrate, serum ketones, free fatty acids, and a sulfonylurea screen. In hyperinsulinemic hypoglycemia, insulin, C-peptide, and proinsulin are inappropriately detectable or high with suppressed ketones and free fatty acids.
A negative sulfonylurea screen excludes factitious hypoglycemia.
If episodes are sporadic, use a supervised 72-hour fast to provoke an event in a controlled setting.
For postprandial symptoms, a mixed meal test can trigger an episode under observation.
Principle remains inviolable. Document the biochemical state during symptomatic low glucose. Without it, a definitive diagnosis is impossible. Once hyperinsulinism is confirmed, localize the source. Differentiate a single insulinoma from diffuse Nesidioblastosis.
Begin with high-resolution multiphasic contrast CT and dedicated pancreatic MRI optimized to detect small hypervascular insulinomas. Diffuse Nesidioblastosis can look normal on CT MRI because it's microscopic and diffuse.
If CT MRI are negative or equivocal, proceed to EUS. High-resolution imaging from the stomach and duodenum can find small lesions.
Diffuse disease may still appear unremarkable on EUS.
Then, functional localization, selective arterial calcium stimulation with hepatic venous sampling, say CST or ASVS.
Sequential calcium injections into pancreatic arterial territories, splenic, gastroduodenal, superior mesenteric, with hepatic venous sampling for insulin.
A 2x insulin rise confined to one territory suggests a focal lesion. Modest rises across multiple territories indicate diffuse disease.
These results directly guide surgical planning.
Pathology confirms the diagnosis. Diffuse disease shows enlarged islets, increased islet number, beta cell hypertrophy, and ductulo-insular complexes.
In healthy pancreas, islets are distinct from ducts. Ductulo-insular complexes indicate disorganized growth.
Focal disease shows localized adenomatous hyperplasia. amenable to limited resection. In infants, genetics informs focal versus diffuse. Focal CHI often has a paternal ABCC8KCNJ11 mutation with somatic loss of heterozygosity in the lesion.
Diffuse disease commonly involves biallelic mutations. Early genetic testing helps plan localization and surgery. Histology distinction predicts outcome. Focal resection can be curative. Diffuse surgery is often debulking.
Treat symptomatic hypoglycemia immediately, then capture the critical sample.
Give IV dextrose bolus and start infusion to prevent recurrence. If IV access isn't available, give glucagon.
First line is diazoxide acting on KATP channels, ineffective in many loss-of-function channel mutations.
Octreotide is main second-line therapy. Refractory cases, sirolimus in specialist centers with careful risk-benefit monitoring. Early genetic testing and referral to a CHI center are essential.
Start with dietary measures, small frequent meals, low glycemic index, avoid simple carbs. Emphasize protein and fiber.
Add acarbose to blunt postprandial spikes when diet isn't enough. Consider short or long-acting somatostatin analogs in refractory cases. Diazoxide or calcium channel blockers may be considered in select adults.
Focal CHI in infants, limited resection can be curative.
Diffuse CHI refractory to meds, near total, Bodder 95% pancreatectomy may be needed, high risk of later diabetes and exocrine insufficiency. Adults, partial pancreatectomy considered if medical therapy fails and localization supports resection. Outcomes vary. In select post-bariatric cases, reversal of bypass has been attempted.
Provide multidisciplinary follow-up. Endocrinology, nutrition, surgery, pathology, and neurodevelopmental follow-up for infants.
Monitor recurrence of hypoglycemia, potential diabetes, HbA1c, and other long-term complications.
CGM reveals patterns, identifies trends, and alarms for dangerous lows or highs, invaluable for fine-tuning therapy.
Large resections increase risks of insulin-dependent diabetes and exocrine pancreatic insufficiency. Watch for greasy stools and weight loss. Treat with enzymes.
Focal CHI treated early, excellent prognosis. Diffuse CHI, complex trajectory. Many adults do well with diet and meds.
Early, aggressive treatment to prevent severe hypoglycemia is the single most important factor in preserving neurodevelopment and quality of life.
Top practical points. 1. Capture a critical sample during hypoglycemia. 2. Differentiate insulinoma from diffuse hyperinsulinism. Use imaging and say CST as needed. 3. In infants, do early genetic testing and refer to a CHI center. 4. Prefer medical and dietary measures first in post-bariatric hypoglycemia. Consider surgery only if refractory after multidisciplinary review. If you found this useful, like and subscribe to Dr. Mustafa El-Safty for more clinical breakdowns. If you want a downloadable slide deck or references list for your rounds, comment below and I'll post it.
This condition represents a fundamental malfunction of a critical metabolic regulator. While rare, consequences can be severe. Prompt recognition and accurate diagnosis are essential for safety and long-term health. Dysregulation ranges from subtle confusion and fatigue to dramatic seizures and loss of consciousness. Maintain a high index of suspicion to prevent potentially devastating effects on brain and body. Diagnosis is a meticulous process of biochemical confirmation, localization, and multidisciplinary planning. Adult NIPS. Symptoms after meals, especially carbohydrate-heavy ones. Episodes affect work, driving, and daily function. In PBH, rapid intestinal transit exaggerates incretin responses, triggering insulin surges. Severity ranges from mild to episodes requiring emergency care. Newborn with persistent hypoglycemia, suspect CHI and refer urgently. Adult with post-meal symptoms. Plan to capture a critical sample. Post-bariatric pattern, prioritize dietary modification and targeted meds. Territories, splenic, gastroduodenal, superior mesenteric. Calcium injected sequentially. Insulin measured from hepatic vein to MAP responses. Focal, sharp, localized spike. Diffuse, modest rises in multiple territories. 1. Always capture the critical sample. 2. Distinguish focal from diffuse. Proceed to SAX-T when imaging is negative. 3. Infants. Early genetics and CHI center referral. 4. PBH. Stepwise conservative approach. Diet first, medication second, surgery last after MDT review.
Nesidioblastosis can hide in plain sight with non-specific symptoms.
Systematic investigation, physiology plus modern diagnostics, transforms uncertainty into clarity, capturing critical samples, using advanced localization, leveraging genetics, and stepwise management are practical, life-altering actions.
Success depends on seamless collaboration across endocrinology, radiology, surgery, pathology, dietetics, and genetics.
Early recognition and expert management safeguard outcomes and restore quality of life. Through vigilance, methodical diagnosis, and collaborative care, patients receive the highest standard of treatment.